Hello, and welcome to today's Better Care Playbook webinar made possible through the support of the Seven Foundation Collaborative. Today, we are discussing adopting trauma-informed care in rural areas, lessons from a community behavioral health partnership in Pennsylvania. My name is Hadley Fitzgerald, and I'm a Senior Program Officer at the Center for Healthcare Strategies. On the next slide, we're going to start with some logistics. So to eliminate background noise, audio lines are being muted during today's event. However, we do want to hear from you. So there's going to be a Q&A session towards the end of the webinar today, and you can submit a question anytime by clicking the Q&A icon located at the bottom of your screen. Also, today's event is being recorded, and we will share publicly the recording on bettercareplaybook.org. And on the next few slides, I'll review our agenda for today and introduce our speakers. So on the next slide is our agenda, which I'm really excited to talk with you all about. This is a topic of great interest to you. We've had many folks sign up for this webinar, which is great. So we'll start by hearing a very brief overview about the pervasive issue that is trauma, the lasting adverse effects that it can play in people's lives, and what it means for rural communities. And then we'll learn from a real-world example. A team from a community behavioral health partnership in a rural region of Pennsylvania are here to share some of their trauma-informed care successes and lessons with us. And we'll end with a moderated Q&A. So as questions come to you throughout the webinar, please drop them in the Q&A box located below, and we'll get to them towards the end of the session. And on the next slide, I'll quickly introduce you to the Better Care Playbook, for those of you who may not be familiar. So the Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. And every month we summarize new journal articles, evaluations, and implementation tools. And we also develop resources like today's webinar, which are designed to help translate evidence and research into practice. And you can explore the playbook at our website, bettercareplaybook.org. And on the next slide is some information about our funders. So the playbook is coordinated by the Center for Healthcare Strategies with support from these leading national healthcare foundations, which are Arnold Ventures, the Commonwealth Fund, John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. And we are very grateful to our funders. On the next slide, I'll provide a very high-level overview of our topic today. So as I mentioned, our focus today is addressing trauma in rural communities through trauma-informed care. So starting with what do we know about trauma, right? So what we know is that exposure to trauma is widespread and occurs across all segments of society and geographic areas. And there's some statistics there on the slide. These traumatic events may include physical, sexual, and emotional abuse, childhood neglect, poverty, racism, violence in the community, and other traumatic negative experiences. And we also know that trauma has a truly lasting impact on people's lives. Many studies have examined how being affected by trauma, particularly multiple traumatic events, contributes to both mental health and physical health concerns over time. And trauma-informed care is increasingly being recognized as a way to address the toxic stress associated with experiencing these events. We are seeing a great deal of uptake in medical settings. So for example, you might find more medical providers conducting screenings for adverse childhood events that helps providers identify with whom to respond with using trauma-informed approaches. But trauma-informed care is also seeing uptake outside of clinic settings in the community context. So some communities, say communities with higher rates of poverty or domestic abuse, are more and more coming together to take multi-sector, interdisciplinary approaches to delivering trauma-informed care throughout their communities. Now, rural communities have unique healthcare challenges in general, and that extends to the adoption or the greater adoption of trauma-informed care. Provider scarcity, turnover are just some of the challenges present in rural communities. It can also be hard to bring these trainings to more isolated settings. But at the same time, in these smaller rural communities, there can be great opportunity for true community-wide impact if the community can establish a strategy to train and implement trauma-informed care across systems. Which brings me to our next slide, where I'm excited to introduce to you our wonderful speakers and panelists who will describe their initiative to improve access to quality trauma-informed behavioral health services across over 20 rural counties in Pennsylvania. I'd like to first welcome Dr. Lindra Bills. Lindra is a board-certified psychiatrist and senior medical director with Community Care Behavioral Health. Her focus is integrated care and trauma-informed initiatives, including Behavioral Health Home Plus, supporting the use of integrated approaches like the collaborative care model, and developing trauma-informed and trauma-specific expertise in mental health and substance use settings for Pennsylvania's Medicaid population. Sherry Hutchinson is the Director of Program Evaluation and Outcomes at Community Care Behavioral Health and brings over 30 years of experience in the field. Chris Minnick is the Director of Quality for the Behavioral Health Alliance of Rural Pennsylvania, also called BHARP. Since 2015, Chris has overseen all quality activities related to the Health Choices contract in the BHARP region, with a focus on monitoring the Medicaid Managed Care Organization for quality compliance. Previously, Chris held various positions within the Northumberland County Human Services Department, spanning 23 years of service. And last but not least, Charles Phelps is a clinical supervisor with Senclear. He has a history of working in hospital and outpatient mental health and substance use care settings. He is skilled in cognitive behavioral therapy, or CBT, and also trauma-focused CBT, motivational interviewing, and family therapy. So without further ado, I'm excited to pass it over to Chris to share more about their initiative. Oh, Chris, I think you're on mute.
Yep, I think I got it now. Good afternoon, everyone, and thanks for participating in today's webinar. We're pleased to share our work with you and look forward to the discussion. So we thought we'd start a little bit at the beginning and share what BHARP is, the organization I work for, so the Behavioral Health Alliance of Rural Pennsylvania, as Hadley said. We're actually in 24 counties in rural Pennsylvania. If you look at a map of Pennsylvania, we're kind of in the middle of Pennsylvania, as well as the far southwestern part of the state in a county, and the far northeastern part of the state. So we cover quite a territory, all rural communities. We're actually under contract with the Pennsylvania Department of Human Services to provide Medicaid managed care on the behavioral health side in the program known as Health Choices in Pennsylvania. And then we subcontract with Community Care Behavioral Health, a managed care entity, who in turn provides the insurance coverage for the members in the 24 counties. We have about 240,000 covered lives in those rural communities. So as a part of BHARP's role as the primary contractor, as we're known as in the system, we ensure that members receive the proper care and access, as well as high quality care in the rural region in compliance with the federal and state guidelines for the program. You can go on now, Hadley, thanks. So we thought we'd take this from a macro level, sort of give you the overview of where we started. It's my responsibility in the system and our thinking, and then move into some more specifics as the presentation goes on. So a little bit of the planning stage. We began planning in early 2015. We identified some clinical approaches to evidence-based practices to support trauma-informed care in the region. We discussed funding options for those practices. So Health Choices reinvestment funding, and that is a funding stream that's allowable through the Health Choices Medicaid program, which provides the leftover dollars that were not paid out in claims to serve the members to be infused back into the system to improve practice and programs. And then we also added a value-based purchasing, which is really a pay-for-participation component for the participating providers in the evidence-based practices training, and you'll hear more about that a little bit later. We also identified the concepts to be included in a Substance Abuse and Mental Health Services Administration, or SAMHSA grant. The grant then was conceived and put together, submitted in April of 2015, approved in August of 2015, and then we convened after some organization convened a kickoff meeting in April of 2016, which included our member counties, our 24 counties and their representation, as well as potential providers that might like to participate in this initiative. I want to emphasize before we move on, this was a system transformation focused project. And you can go on now, Hadley. I'll talk about the two-pronged approach. So we really thought heavily about making sure we had evidence-based, high-quality practices in place as individuals became identified through screening processes, et cetera, as needing trauma-informed care. And simultaneously, we wanted to make sure that the system partners were trained so that the clinical service providers, the mental health, substance abuse disorder outpatient providers received proper support, and the system partners had options for care should they assess the need for trauma treatment. The referrals would then hopefully be well-informed, and as individuals received care, that the care would be coordinated and that the system partners would be able to provide support to those individuals in their roles and functions in the system. You can move on, Hadley, thanks. So when we talk about system partners, we mean all system partners. This was offered because of our tentacles, if you will, across the region. The counties, our member counties, were highly engaged in supporting the training, recruiting people to attend the training, and sponsoring the training. So this includes, the system partners, when we talk about this, includes substance use disorder supports and services, bus drivers, first responders, community action agencies, developmental disabilities supports and providers, school personnel, mental health supports, including case managers and peers, child welfare, area agency on aging staff, etc. So if you can picture this, we wanted to do our very best to ensure that if someone was identified through screening in need of trauma-informed supports and treatment, that all these folks would be understanding of looking at things not so much as a behavior, but with a lens of trauma-informed care. So knowing that when an individual got on a bus to go to a program that they might be receiving care at, that bus driver could very well detour, if uninformed, what that person might experience or what gains they may have had. So we can move on now, Hadley. Thought we'd talk a little bit about the system level training partners. So, this was a big, I think 24 counties, lots and lots of staff and touch points, right? So we identified collectively through some significant research 4 choices for our system training partner and their philosophies. And I must say, all fantastic. Maybe some of you are from those agencies or represent or have had experience with these folks. So all excellent trainers. National Child Traumatic Stress Network, or NCTSN, the Sanctuary Model, Lakeside Global Institute, which is from the Philadelphia area, and then the National Council for Behavioral Health. We ultimately selected, and this was a collective process, we looked at data, we looked at outcomes, we looked at specifically their training approaches. We selected Lakeside Global Institute. They provide shorter, though frequent training. And if you think about behavior change, for those of you that might be interested, I mean, it's not a quick and done thing, right? This is a transformational process. So they provided a model with shorter, more frequent training in various levels, appealing to the system partners that were selecting the trainer, and ultimately they were more cost effective. And you can move on, Hadley, I'll talk a little bit more about that. So Lakeside provided training to over 4,000 system partners and continuing to grow in the region using a hybrid system. So that was another thing that they worked with us on. Of course, they wanted to do this in person, and to reach the numbers that we wanted to reach, we asked that they do it in a hybrid way. So each of the trainings had some in-person options depending on the subject matter and the focus, and some of the trainings were done virtually. To promote sustainability, we also asked them to develop a train-the-trainer model for the base level training. So if some of the folks that were trained had enough experience and training through their system that they agreed to sort of deputize them to provide training using some of their models at the basic level. So as I would say, if the local Lions Club wanted to learn a little bit about trauma, local people would provide that training. That was at no cost then, or the Kiwanis Club, or hospital emergency rooms that may not have been trained, or others as the models and continued to grow and people began to understand a different viewpoint of behaviors and the need for trauma-informed care. We want to move on. Hadley. So I'd like to introduce my friend Chuck now, who represents the provider community and one of the providers that was trained in the evidence-based practices. So keep in mind as you think about this today, once again, we took a two-pronged approach: evidence-based practice training, and then system transformation training for those surrounding individuals receiving care. So thanks very much.
Good afternoon, everyone. Yes, I'm Chuck Phelps. I'm a clinical supervisor at St. Clair Child Services. I just wanted to start things a little bit to just tell you a little bit about St. Clair. St. Clair Services was established in 1980 as a nonprofit organization. Head Start was our original program, and the program on which St. Clair's comprehensive service delivery system was modeled. Through the provision of Head Start services, it was soon realized that there were other issues that the Head Start program alone could not address. Where the community was lacking in a service, St. Clair Services developed programs to fill that need. During the course of the past 40 years, St. Clair is now able to offer a seamless array of mental health and psychiatric services to area children, adults, and families. Since that time, the mental health programs have continued to grow and have added a maintaining strengths program, substance abuse disorder services, peer specialist services, blended case management, and community and school-based mental health. The St. Clair Mental Health Division now services adults and families in various settings throughout our service area. In 2016, we became aware of an initiative sponsored by BHARP and CCBH, recognizing the need to provide increased knowledge and training about the benefits of trauma-informed care. We were attracted to the opportunity to better understand trauma and how specific treatment modalities can provide better outcomes for our consumers. My aha moment came upon the realization that trauma affects everyone. Our initial goal was just to be trained to treat our consumers who were experiencing trauma, but realized that trauma affects everyone, from the consumer to the front desk staff in our clinic, to the therapists, and all the way to the top of the system here at St. Clair. For me, it was especially important, not only understanding the consumers, but understanding how being in mental health treatment service, that it affects our staff. And once we acknowledge that, I think through our ability to provide the support, that not only our staff were feeling better, that we were providing a better service to those consumers in our community. So it just made a lot of sense for us to participate in this initiative. I don't recall the specific order of the conferences and trainings, but remember, the more that we got involved, everything was just making sense. As the initiative progressed, we became aware of an opportunity to meet specific requirements set by BHARP and CCBH, that our clinic could be recognized with a certification, and depending on the level of attainment, could achieve a financial award for our work. The level of attainment was based on orientation of staff on trauma at higher, and meeting expectations of maintaining a trauma treatment environment for all staff throughout the course of the year. During this time, training opportunities were provided in seeking safety, trauma-focused cognitive behavioral therapy, and cognitive processing therapy, etc. The more our agency became invested, the more the concept became part of the culture of St. Clair. We also had support in identifying and using measurement tools that were helpful in assessing a consumer status in treatment. And we currently use the CPSS for children and the PCL5 for adults. So that's just a little bit about St. Clair and how we became involved in with this initiative. So I think Lindra might be next.
Thanks, Chuck. And yeah, thank you for the opportunity and good afternoon. So I'll first just start off. I represent Community Care Behavioral Health, and you've been hearing the references to that. We represent the managed care organization for mental health Medicaid participants in Pennsylvania. And this company was founded in 1996 and is part of University of Pittsburgh Medical Center, and it's headquartered in Pittsburgh. We are tax exempt federally and a nonprofit with our focus, as I said, on publicly funded behavioral health care services. And Chris highlighted, we collaborate with our county partners in Health Choices. We're a risk-assuming PPO, and we are NCQA accredited. And we serve across the state 1.5 million individuals in 43 counties and a large provider group. Let's go to the next slide. So I'm going to follow up with Chris's start at our work, our collaboration together. And we did a lot of collaboration, and Chris mentioned it, but we spent a lot of time in the preparation, like he was describing the time spent in making decisions to choose the way to do the training and also which trainers to use. But also BHARP, we together, CCBH and BHARP, certainly came together around what I'm going to highlight in the next couple of slides, these factors that were driving the need for us to do something about improving how folks could get trauma-informed care. And there was recognition, really clearly that in these outpatient settings, both mental health as well as substance use settings, providers needed more capacity to be able to address the traumatic stress problems that their clients were coming into the office with. And there were important barriers for us to recognize. So especially in rural areas, I listed those here, problems with having mastered level clinicians. Sometimes that's an issue when you're using some of the evidence-based treatments. Difficulties with even providers getting access to training opportunities, certainly funding. The difficulty with supervision, and I'm going to touch on that specifically. And then certainly provider turnover, which is fairly common, and that can also be difficult to maintain training skills. Also, we wanted to have that connection, as Chris highlighted, between human services, so the broader big picture of a system being trauma-informed, and the providers. And we wanted to be able to see that as something that could sustain itself over time. Next slide. So some of the other items that we highlighted here, you just see that certainly we heard from consumers and people in care that would talk about even feeling not safe or uncomfortable in the settings where they were trying to get treatment. So that could be an environmental issue, all kinds of factors. So BHARP was listening to that. We were also listening to those issues and knew that that was an important component if you're looking at things from a trauma-informed perspective. But also provider burnout of vicarious trauma another important factor and something that we wanted to pay attention to. And then certainly what happens when people are impacted by traumatic stress exposure. It can affect how they get care or how much care they get, the utilization of care, with more inpatient care, repeat inpatient treatment admissions, sometimes more care, sometimes more frequent care, also for substance use treatment, but also physical health. We had a lot of discussion about the importance of needing to recognize the impact would be certainly with behavioral health issues, symptoms, clinical problems that folks were facing, but more broadly, social determinant factors, but also physical health factors that folks had more physical health impact. And we needed to pay attention to that. And then, of course, more crisis involvement as well. Next slide. So I like to highlight here that this goes back to Chris's comment, but I remember really clearly that we spent a lot of time together, the group that was meeting to brainstorm about this project. And we were really clear about these three things. And I consider these kind of like very foundational to this project and why we can continue to see the impact of it. So one was, Chris touched on this, but trauma-informed care basics needed to be known kind of across the board, certainly all the provider setting, all their staff, but also all of human services, as Chris mentioned, really a system transformation view. We needed the clinical providers needed to be able to have some skills, some trauma-specific treatment interventions, evidence-based as well as evidence-supported, and I'll touch on those in just a minute. And then the other big component was recognizing the need for the providers to have the ability to do complex problem solving. And we really saw that as trauma-informed supervision, the need for brainstorming around how complex folks could present in behavioral health, physical health, and substance use disorder settings. And there needed to be a high level of understanding of that complexity to support a person getting the best possible care, best quality of care. Let's go to the next slide. So you already heard a little bit about this, but in terms of the original training, Chuck and Chris both mentioned this, but we did offer here, these couple of slides will give you a little bit of the detail of the number of folks originally trained, but we use Seeking Safety, and those were offered, you see the time frame, August 2016 to 2017 in September. And we trained about 300 people in this model, but it can include a large group of therapists and peer specialists, case managers, and certified recovery specialists as well. So we used that. We did certainly do trauma-focused cognitive behavioral therapy, and that training was provided, initially you see here 98 clinicians and then consultation calls, and 56 clinicians completed the full series. Then we did cognitive processing therapy. That was provided to about 78 clinicians. 27 of those completed all the requirements. We also did dialectical behavioral therapy, and 8 providers participated in that in 2018. Next slide. And I'll say that we, the support, as Chris mentioned, in terms of funding, the state was supporting our emphasis on using evidence-based treatments, and that also impacted our choice. And there were several other factors that influence our choice, including what I mentioned earlier in terms of the barriers, like not having as many clinicians who were masters trained across this rural region. We did some other trainings, trauma art narrative therapy. with about 100 clinicians. We did parenting with love and limits, family systems trauma. That was an introduction for about 300 people, and then pilot for clinicians. And then CCBH, myself and another colleague on our team, Dr. Taylor, regularly provided screening training, so history and symptom screening, and then training on debriefing methods and vicarious trauma. So we have offered that consistently every year during the program. And I'm going to stop here for a minute and see if Chuck, do you want to add anything about the training, or maybe some comments or observations? Feel free.
Chuck,
You
I
might
think
be
you're
on
on mute.
I started my video rather than unmuting. No, I'll comment in a little bit. I have some information prepared that'll make more sense if I just present a little bit.
All right, sounds good. So let me go on to the next slide. And I touched on this just a minute ago, but remember one of those three important components was the capacity for complex problem solving. So we thought of that as having trauma-informed supervision, and how could we support this? So we did contract with the developers of a trauma-informed supervision model that was really based on the original sanctuary model and the framework known as SELF. And some of you may be familiar with that, but it stands for safety, emotions, loss, and future. And Ida Kaufman and Joe Fodoraro were the trainers. So their model was really to help and support a process where trauma-informed supervision could be held in behavioral health and substance use provider settings, and that it would specifically support this complex problem solving and a way to manage trauma-based clinical issues that would come up and have been coming up and continue to come up in these settings. So it was designed to be a way for behavioral health and substance use disorder providers to collaborate, since they met together and did this training together. We had 4 original groups, and they met regularly. We participated with them in their training and also ongoing. And then they did in-person training, and then they met regularly using Zoom. Next slide. And just to say a little bit about that process, because it certainly has been meaningful, but I put on here, it was really a parallel process. So it was certainly clinically focused and driven, issues that came up, but there was a lot of the parallel view, kind of what Chuck touched on, and maybe you'll say more about that, Chuck, but staff issues, like you said, trauma issues and traumatic stress exposures universal. So this model of supervision was really recognizing that commonality and helping support staff performance and personal development, and then also supporting recognition of organizational stressors, challenges, and how that could be work through, and what could be helpful in terms of for the individual clinicians, how could they manage that, and then also get back to the work to support their clients and their growth and development. So I'll transition to you here, Chuck.
Very good, Chris. Thank you. Yeah, I wanted to share a little bit more about trauma-informed care supervision. I think the trauma-informed supervision training occurred around the same time as our vicarious trauma training. So it was helpful to have that knowledge to concentrate this information in supervision with the clinical staff. Over time, trauma-informed care has become part of our culture. We initiate discussion about trauma during the hiring process and assure potential staff that if if they haven't had specific trauma training, that it will be offered and supported, during their employment at St. Clair. Our clinics are located in a rural area, and a majority of our potential candidates for therapists are young in age or young in their career. So that's been a challenge for us. So some of the attempts that have been fairly successful for us to meet that barrier, that we have had success in providing internships for master's level therapists. And then what our goal is with investing our support and time in those interns is that we want them to become employees of St. Clair. And then from that point, we also have LPCs and LCSWs who are available to provide not only trauma-informed supervision, but also helping them meet that attainment of getting their hours to meet the requirements for licensure. So we have had success with that kind of process. At higher employees are oriented to trauma. So when they're hired, part of their orientation is becoming familiar with trauma and vicarious trauma. And then the ball just kind of rolls from there. We've really relied on opportunities in the community through funding or grants to provide that training. As part of our supervision, each of our staff develop what we call a self-care plan. It's kind of like having a professional safety plan. And then we wear badges, obviously on the floor at the clinic. And in that pouch where the badges, each staff have a self-care plan that includes a safety plan. So it's available for them. And when we have our weekly supervision, we'll review that safety plan. So it is just kind of a crucial part of our individual supervision. So yeah, I'll pass it along to the next person.
Hello, I think that's me. Thank you. The trainings, supervision were a very large component to this initiative, but another large component, and Chuck mentioned this, is that trauma-informed culture that we wanted to see integrated within all of our agencies. So we supported our behavioral health providers in building this culture through a trauma-informed care learning collaborative, like we like to refer to it as a TLC. We use the Breakthrough Series model. Some of you may be familiar with that. It's from the Institute of Healthcare Improvement. We also did provide a link to some resources around that model. We use it fairly frequently at Community Care Behavioral Health because it is very successful in helping produce culture changes. At the time of the TLC, we had 21 agencies participating across 30 sites. 16 were mental health agencies, 14 were substance use disorder services. The TLC lasted for 15 months, and you can see it's embedded right amongst all of the trainings for trauma-informed evidence-based treatments. The Breakthrough Series model is fairly structured. It has a focus on data collection, which we did incorporate, and I'll speak more to that, the quality improvement cycles, and then we would come together through monthly webinar calls across all 15 months. Community Care provided the clinical consultation during this time, also the data management, and BHARP facilitated all of the webinar calls and meetings. The next slide. There is a focus on data in the Breakthrough Series model. Through all of the background that you've heard and development of this initiative, we came up with these two very important process aims that we wanted to look at specifically as part of the TLC. So the first process aim was that by the end of the Learning Collaborative, 100% of individuals would be screened for exposure to trauma. And we measured that by having our behavioral health providers report how many individuals they saw that month and how many of those individuals had a trauma screening. We didn't mean to imply that a trauma screening should occur every month. And we work with providers around clinical judgment and finding that perfect balance between routine screening and what's best for their clinical needs. The second process aim is that by the end of the Learning Collaborative, the staff would be trained and educated in trauma-informed care. So a lot of what we've talked about are evidence-based treatments for clinical staff, but we wanted to see all staff at the agency trained and educated in this initiative and in trauma-informed care. So depending on your role at the agency, you would have different trainings or educational sessions, but from the front reception staff to security, executive leadership, administrative leadership, in addition to the clinical staff, we wanted to see everybody trained and educated in trauma-informed care. And then, of course, if we implement good trauma-informed care, what outcomes do we expect to see? And there are many. And we selected and highlighted this one, and that is that by the end of the Learning Collaborative, staff would report high confidence ratings in delivering trauma-informed care. We chose a goal of 90%. And for this measure, we asked our supervisors to ask their clinical team, how confident are you in delivering trauma-informed care to the individuals you serve? And then they would give a rating on a scale of 1 to 10. And we considered a high rating a 9 or a 10. And we'd like to see 90% of the clinical staff that were surveyed confident in delivering trauma-informed care. There are some very specific components that we found were very helpful as part of the Breakthrough Series model. One is the quality improvement team. So before the Learning Collaborative started, we asked every agency to form a quality improvement team. These were selected individuals from different areas, different roles at the organization. We like to see executive leadership, clinical leadership, members from any quality or IT that would come together, usually monthly, if not bi-weekly, to discuss the initiative. And we also asked agencies to have an individual being served, an individual in service as part of that quality improvement team. The Breakthrough Series model and all learning collaboratives have a strong focus on small tests of change or quality improvement cycles. We use the Plan, Do, Study, Act cycle. We asked our providers to do a PDSA cycle every month. We expected these to be very small, something that can be completed in a month, if not a few weeks. And just for an example of what we typically saw at the beginning of this project, many providers needed to select a trauma-informed screener. They didn't have one in place. So a nice PDSA that we typically saw at the beginning was researching or selecting a screener and then maybe testing it on a few individuals as part of a PDSA cycle. We gave our provider organizations an Excel guidebook. Sometimes I'll slip and call it a workbook, but no one likes more work. So our guidebook, and part of that included milestones. And these were step-by-step activities that were important in the implementation of trauma-informed care. And the quality improvement teams could review these each month and indicate how far along they were in progressing through the milestones. And then finally, the general process. We had monthly webinar calls. Information from the guidebooks were submitted and discussed during these webinar calls. At the beginning, a midpoint, and end, we had in-person meetings, usually centered around some trainings or presentations, and also presentations by our participating providers, either through, at one point, they invited some testimonials of how trauma-informed care impacted their lives. and also storyboards where behavioral health providers were able to give a poster presentation of all the progress that they were making in implementing trauma-informed care. Next slide. This is an overview of the results. I highlighted just a few on this slide. We did provide a link to, or at least the information around some publications where these outcomes are published. We provided quarterly summary reports across the 15 months, and we provided 21 individual provider reports so they could see their own progress and how it related to the progress of the aggregate, or I'm sorry, as the learning collaborative as a whole. So the first on the left, you're looking at the screening rates and the outcomes for that processing. You can see at the beginning, 39% of individuals who walked through the door were being screened for exposure to trauma. It was fairly low at the beginning of the learning collaborative, but it increased significantly. We landed at 77%. If you looked at just the last month of screening rates, they were pretty high, at 93%, and about 55, over half of our providers, 55% were at 90% screening rates or higher. So they did very well with increasing screening rates. As for staff being trained, I don't have that pictured, but for staff and others being educated or trained in trauma-informed care was close to 3,000 staff members that we saw trained in trauma-informed care. And then our outcome measure is on the right, provider confidence in delivering trauma-informed care. Again, significant increase over time. These are the percent of those clinical staff who gave high ratings of feeling confident. Again, very low at the beginning, or fairly low at 19%, and then over time, 68%. So it did increase over time. We were below our goal of 90% of staff feeling confident. Our providers did tell us that it's one of those cases of sometimes you don't know what you don't know. And as staff became more educated about trauma-informed care and all of the components of trauma-informed care, they kind of took a step back and felt that they needed more support. And even very seasoned, experienced clinical staff sometimes saw a little decrease in their confidence ratings. But overall, we did see that improvement in confidence in delivery of trauma-informed care. Next slide. So when the learning collaborative ended, we wanted to sustain all of those wonderful improvements that we saw across those 15 months. So we developed a process for our providers to continue their work through a trauma-informed care center designation. In this process, the agencies that participated in our TLC could apply through a formal process to become a trauma-informed care center, and they would receive this designation. Parts of the application process were based on all of the components of trauma-informed care that we had worked on during the TLC. We wanted to see that each agency had at least, or could offer at least 2 or more evidence-based treatments in trauma-informed care. So they retained staff that were trained. So that training continued after the end of the TLC, a very important component of this initiative. We wanted to see the screening rates continue. So we asked for evidence of their screening process and rates. We wanted to see that they had a clinical monitoring process in place. So not just screening for trauma, but also if trauma is identified, what tools were they using to monitor symptoms over time, and what outcomes tools were being used in process to measure progress in clinical care. We also wanted to see the consumers, the individuals receiving services, actively involved with high satisfaction with the services that they were receiving at these agencies, and being incorporated into agency decisions, either through participating in boards or other work groups. Next slide. These are some of the specifics with the application process, starting with an organizational assessment. Linda, I believe you wanted to discuss this slide, so I will turn it over to you.
Well, thank you, Sherry. This designation that, Sherry's highlighting the important work of the Learning Collaborative, just all the components that you're hearing so much about. This piece about sustainability is certainly something we as a group spent a lot of time thinking about, like what could help with sustaining this if everybody's going to be doing a lot of work here. So how could we help? So we reviewed the application and evidence, and now that's an ongoing process that BHARP is actually doing. And they continue to use organizational assessment that kind of helps identify what's going on in the organization, and then also the clinical components and making sure there's consumer and family engagement. Next slide. Part of that review process, this is just showing, kind of highlighting a section of a rubric that we worked together. Sherry helped us a lot, but the whole team worked together to figure out kind of a guideline to help with the review process to give that determination of trauma-informed care center and the designation. And that we're just putting a piece of it there, but that gives you kind of an idea of how we were thinking about the sustainability. And I'm going to pass it on to Chuck to see if you want to add something here about sustainability and your thoughts about this process.
Yes, thanks. I just wanted to further address the barriers that we face as a rural clinic. Being in a rural setting, we're limited in our pool of potential master's level therapists. And we have done our best to manage this barrier by becoming open, as I mentioned earlier, to providing master's level internships to candidates in the process of earning a degree and becoming a therapist. We've experienced success in transitioning an intern to an employee upon graduation, thus prospering from our investment. Until the trauma initiative, there were limited training and funding opportunities for training staff. SendClear has taken advantage of recent funded training opportunities for EMDR and another round of traumas-focused cognitive behavioral therapy. Another barrier in rural areas, it can be difficult for licensed eligible therapists to obtain the required supervision. They need to become licensed. So at SendClear, we have the opportunity for staff to receive their supervision from an LCSW or an LPC, and also have that trauma focused. Therapist turnover is a barrier. As therapists obtain their experience, training, and licensure, they tend to seek better job opportunities, including private practice. We've done our best to offer salary advances and career advances to offset staff leaving SendClear. And you can move on to the next slide. I'm sorry. A barrier not mentioned on the slide here is support for the supervisors and leadership as we face daily challenges. In the past, and I think there's discussion about revisiting having a supervision call that includes any or all of the trauma-informed clinics across the state of Pennsylvania, having a conference call for clinical supervisors or leadership to just have an opportunity to share successes and challenges that we're facing in that moment. And in the past, that's been super helpful, especially during COVID, that we had the support of another agency across the state that was actually experiencing the same struggles that we were. And that was a super supportive environment that we were able to take advantage of. So I think it's on to you, Hadley.
Thank you so much, Chuck. And thank you to all of our presenters for this excellent presentation. We're now going to transition to the question and answer portion of the webinar. We've received many great questions already in the Q&A, but just as a reminder, if you have a question you haven't asked yet, we encourage you to just go ahead and type that in now in the Q&A icon at the bottom of your screen. Yeah, and we can go ahead and take the slides down. And I would just ask that all of our panelists turn on their cameras so we can see you. And we are going to go through some questions. We received some terrific questions from people when they registered for this webinar today. So we're going to go through some of those, as well as some that are in the chat. Yeah, and so just to get us started, Chris, I might send this one to you to get us going, because something that is really clear about this initiative was just how collaborative it was, how comprehensive, and clearly a lot of planning went into it. But these initiatives, need leadership buy-in. And we're talking a multi-pronged initiative that you help lead across different sectors and different agencies. So I was wondering if you could, share some reflections on how through this initiative you achieved leadership buy-in.
Well, that's a great question, and would be a really, really long answer. But I'll say this, hopefully this brings a little perspective to this. One of the things that we found out early, and this would be in our small group that Linda referenced way more than I did in terms of planning, but then as we began to plant the seeds, this transformational process and focus on trauma resonated with a lot of people. The leadership was really critical to this because they needed to free up folks' time to take training and all of that. I mean, it was very critical. But as they began to see the data, the research, the approach, it became a personal transformational process for a lot of people. And it became easier, I believe, to support the leaders to think about more broadly about how they're supporting their managers, their therapists, supervisors, because it resonated with so many people as you began to present kind of the unarguable facts about changing your lens into seeing behaviors and supporting people differently in their recovery journey. And Dr. Bills was very involved with the supervisors in engaging them directly and indirectly, I think, in supporting them. I don't know if you have anything further to add to that.
Hey, Chris, you highlighted everything, and I agree. We tried to grapple with that question, Hadley, of getting leadership involvement. We did actually provide a training specific to like administrative leaders. We invited a speaker who could talk about applying a trauma-informed approach and a trauma-informed culture in their entire organization, and that was one of the things we did to try to get that across. But I think Chuck could describe this, and we had other providers talk about, over time, the leadership has gotten more involved in the whole trauma-informed culture. So that's been good.
Yeah, and I'll just comment real quick on St. Clair. I did reach out to our leadership for some comments from them. And organizationally, it gives us a tool set that we didn't have before. Sanctuary and the Trauma-Informed Care Framework have given us tools to respond to staff and consumer-specific incidents in a way that was more productive, more likely to yield positive and amicable outcomes, and ensures our staff feel supported in a way that we might not have been able to do that before. So that's been a point of view organizationally for St. Clair.
Thanks so much for sharing the different perspectives on that question. I hope that's helpful for our audience. And another question that we received is about funding. And I know, Chris, you touched on this in your slides a bit, but I see that there's so it'd be great, maybe we could just, sort of reinforce the funding resources and grants that were accessed as part of this work. But, Chuck and others, if you want to weigh in, there's also clinician time, staff time spent going to trainings, and, in provider settings where time is already such a constraint. I would love just to hear, how did you piece all of this together? So maybe, just starting with the initiative overall and then transitioning to like a provider perspective on that question.
Yeah, so for us, it really be on the system side, really began with the SAMHSA application. And that was a formula. I'll give you a little slightly more detail. So that was a $4 million grant over the course of 4 years, and we actually ended up continuing. We just finished our second round of that in 2023, in the fall of 2023. So it's resonated with SAMHSA as well, because we applied and continued the work really with some additional supports. So I think a critical thing, which I'll pass to Chuck, is that freeing up of time. When you're talking about clinical time, when you're not seeing folks, typically clinicians are either not getting paid, surely the agency isn't being reimbursed at that point, but providing a higher quality of care was an investment that the facilities, I think, reached fairly quickly. And they did get a small value-based purchasing, pay for performance payment in the initial iteration of this, which I think was appreciated. It certainly wasn't a large amount, but I think it was appreciated. And then in terms of Health Choices funding, dollars were allocated as available through the reinvestment process, which includes support from the Office of Mental Health and Substance Abuse Services at the Department of Human Services in Pennsylvania. So that got fully vetted and supported over the course of several years to be able to provide the clinical train and fund the clinical training. We funded some through the System of Care grant, but much of the clinical training was funded through reinvestment. So I don't know, Chuck, if you want to talk about the allocation of staff time.
Yeah, I mean, the gains definitely outgained any type of lost time or lost billable time. The multi-pronged successes or benefits of this is, number one, we're getting our staff trained. They're getting more comfortable in providing that training. They're getting continuing ed credits. We didn't really mention that, but these trainings that were offered did offer continuing education. So from an agency perspective, we were providing that education. They were getting their continuing ed credits. It was benefiting the comfort level of our staff and in the big picture benefiting the consumers.
Thank you. Yeah, such an important question. So thank you for weighing in with those details. Another question we got was about, people themselves. So this question tackles how trauma-informed care supports people who might be experiencing homelessness or people who are struggling with substance use disorders. So I'd love maybe Sherry or Lindra, you could weigh in just on what trauma-informed care means and how that can impact people who have these other challenges in their lives.
Yeah, that's a good question. I'll start and Sherry can add in. But I think that the education piece was very helpful in terms of making sure everybody had like foundational education around all the social determinant factors, kind of the broad sweep of the impact of traumatic stress. So certainly there could be people who would show up with clinical symptoms and end up in mental health care, substance use care, physical health care. It could look like so many things. And also the person could be homeless, not really in care. So I think, for example, or in the juvenile justice system or in the legal system. And that's, as Chris pointed out, that's why the thinking was, thankfully, this systemic approach, because we recognize if you understand the impact of traumatic stress, you don't always see the same thing. Like the person might be over here in a totally non-clinical world. So you need to have a broad sector of human services really understanding that impact. That I think that is the education piece helped a lot with that. So I think, for instance, Lakeside Education, they did a good job really with their education format, kind of covering all those components. So we really felt like certainly all the clinical folks and the provider staff, everybody could get a good foundation on that understanding. And then, as Sherry mentioned, like the specialists, we had those events like institutes that BHARP supported and sponsored, and we had like guest speakers who could also further add to that knowledge base and complexity. Sherry, I'll leave it, see if you want to add anything.
I'll just, yeah, I think that the system, like you mentioned, the systemic partnership was very important when addressing social determinants of health. And then you're making referrals to other human services agencies. Having everyone trauma informed is very important to make that a cohesive link. We did work with our providers to, assess whole person care. And so not just their mental health, substance use, but other social determinants, social support, and other needs that they had and addressed through this initiative too. So I think that was part of addressing homelessness and that whole person care.
Yeah, thank you. For sharing those additional details. And sort of digging even deeper into, the folks themselves who are experiencing trauma and what this initiative was trying to address. There's a question in the chat about how ethnically, culturally, racially diverse is the provider staff and the recipients of care. So that's something we haven't touched on yet. What is, the diversity of the counties that you served in this initiative? And, it would be interesting as well to hear about any delivery of or concept that was informed through the trainings about delivering culturally competent trauma-informed care. So I'll let anyone who wants to volunteer kind of take that on first.
I'll take the first swing, and for anyone that would like to take a look at the data in the BHARP region, I guess I won't say this unfortunately, but the reality of it is we are not a culturally diverse segment of Pennsylvania, to be perfectly honest about that. I will say as a part of the SAMHSA grant, we needed to write a cultural linguistic competency plan, and much of our plan focused on the social terms of health and poverty in terms of marginalized populations in our sector. I'm just being honest. If you look at our demographics, that was not an overwhelming factor in developing staff and developing specific campaigns for ensuring that members were properly engaged and reached in the initiative. If anybody else has additional thoughts.
Yeah, I'll support that. The two clinics that I represent in pretty much very central Pennsylvania, we are not very culturally diverse. So, yeah.
Right. And yes, I certainly can validate that, those comments that you guys are making. I just was going to add that, again, the training did help providers focus on cultural diversity, ethnic diversity, and other factors that can contribute to the impact of traumatic stress. And I appreciate that. I would say that there's a specific training Lakeside does in their series that's on this topic specifically, and it's an excellent module. So I'm just highlighting that.
Thanks so much for sharing that, Linda. It's so important to, have that education, even in areas that don't seem particularly diverse. It's so important for clinicians and others to be factoring that into the care they deliver. So I wanted to next ask, we have a few questions coming in about data and outcomes. So yeah, I'll just say, were there any notable outcomes indicating trauma-informed supervision or training positively impacted services for high acuity populations? I think we had another question related to this as well, if there's just any data on improved patient functioning or well-being. So I'd be very curious to see how that was tracked. So I'll pass it to you, Sherry.
Yes, thank you. We did work with providers on assessing outcomes for individuals and looking at outcomes over time. So for our adults, we have asked our providers to collect, it was more of a recovery assessment measure. For our children, it was functioning. We set a goal of a 5% improvement. So it was a very, very modest amount of improvement that was expected over a year's time. And we saw about half of our provider agencies were able to meet that goal. So we did see some improvement on individual outcomes. I think the way that you worded it, Hadley, is what we need to do next, and looking at the high acuity populations, or those that we know that had exposure to trauma. So this was more of a population, kind of the intent to treat. So these organizations, these agencies were trained in trauma-informed care, and it was integrated through their culture. So we looked at outcomes for everyone. And, you know, if we had more information on specific populations, it would be good to do that as a next step, look at the outcomes for those specific populations.
Yeah, and can I just add this? Yeah, thank you, Sherry, for that. It's a tough topic, Hadley. We scratched our heads quite a bit on this one. And I'm not the outcomes expert. That would be Sherry. So I will say that one of the things in terms of a concept, and you can see this in the traumatic stress literature quite a bit, but a person's self-efficacy improving is one very kind of key measure. And we did try to take a look at that. So it's not easy. I'm not sure that answers all the questions, but I'll just mention that too.
Well, I just want to say thank you, everyone, for this incredible presentation. We feel really lucky to have had you and to share your expertise. I want to share some slides because we have some additional resources to share with the group. I hope, you know, everyone is walking away today feeling like they have a better understanding of the value of trauma-informed care and the importance of bringing this approach to rural communities and ways to go about doing that. But this slide has some related resources on trauma-informed care, as well as some published articles, you know, authored by the panelists that you saw today. So you can continue to read more details about their initiative in Pennsylvania. Also on the next slide, I just wanted to, you know, remind the audience at the Playbook, you know, we're always, you know, collecting resources and evidence. So if you have helped to develop evidence on what works when caring for people with complex health and social needs, we welcome you to submit your resources or ideas to the Better Care Playbook's website. And finally, on the last slide, we'll have some information about, you know, just to say thank you. There's also going to be an evaluation survey that will pop up on your screen in just a moment. And we really value your feedback in terms of helping us understand what content meets your needs that we would, you know, like to, you know, continue to publish on the Playbook. So we're at time. I just want to say thank you to all of our wonderful presenters. We really appreciate you taking the time to share your insights with us today. We're very grateful. Also like to thank the 7 Foundation Collaborative for making this webinar possible, and also to everyone who joined and shared your terrific questions. We hope you have a great afternoon. Thank you.